Hey guys, back at it again with another video. Um, I got a comment on the last one that my microphone wasn't that good, so I kind of switched it up. So I'm hoping this one makes the video sound a little bit better and helps with your studies. Um, so this video, I'm going to go over supraventricular tachyarrhythmias, which I kind of denoted as SVT, and ventricular tachyarrhythmias as VT. Mostly because I'm lazy and it's kind of a pain to just type it all out. So this one will kind of go over atrial fibrillation, atrial flutter, QT prolongation, and Torsades de points. Okay. So basically, SVT is an uncoordinated, unsynchronized electrical signal that leads to a rapid heartbeat about greater than 100 beats per minute. And it usually corresponds to tachyarrhythmias from above the ventricles. Above the ventricles, and then a heart rate above 100 beats per minute. So the most common one is an AVNRT tachyarrhythmia. However, this one tends to be asymptomatic. The ones that people usually associate with this one is atrial fibrillation and atrial flutter. So this is what pretty much the treatments are going to just involve, is just talking about AFib and AFlutter. The other ones, usually you don't see too much. They usually tend to be benign or asymptomatic. So the classification for atrial fibrillation or AFlutter is paroxysmal, which is recurrent symptoms but lasts less than 7 days. Then you got persistent, which lasts more than 7 days but less than 12 months, and you can maintain a sinus rhythm, which means you can use rhythm control. And then permanent, which is basically you can't achieve sinus rhythm, so you're mainly probably going to see only rate control for this one. So patient presentation, a majority are going to be probably asymptomatic, but in the cases that they do get symptoms, they'll get the palpitations, dizziness, lightheadedness, chest pain, dyspnea, which is like breathlessness, and an irregular pulse is also a big one. So diagnosis. Basically, you're going to do this with an EKG. It's usually a problem with the AV node, so you'll kind of see like these weird or absent P waves. But a big one is the narrow QRS complex, but it can also be broad in some cases. Broad is more commonly seen in ventricular tachyarrhythmias, not usually in supraventricular tachyarrhythmias. You also need to do some history taking, and you also want to rule out other cases. So you want to do your complete blood count to check for electrolyte abnormalities, and you want to do thyroid tests to make sure that's not the patient's not in hyperthyroidism or having like a thyroid storm, for example. And then you also kind of want to do an X-ray to rule out pneumonia, which can also cause atrial fibrillation as well. So basically, you want to rule all those out before you give out the antiarrhythmic therapy, because if you just treat those underlying causes, you can essentially fix that afibrillation or aflutter. And then this one, I'm just going to do before we get into the therapy, is the CHAD score, because with atrial fibrillation, just the way the heart is set up, you got your like chamber, you got your blood, and that blood tends to pool because the heart is having a regular heartbeat, so it's not pumping it out in a timed manner. So all that pooling of blood can lead to this clot building up, and if that clot leaves, it can go to our brain. Sorry for the very trash drawing, and it can lead to a stroke. So we basically wanted to assess the patient on the stroke risk. Now there is also a CHADS VAS score as well, but I'm just going to keep it simple and just stick to the CHADS score under Canadian guidelines, because this one is usually the ones that you'll most commonly see. So that is something like congestive heart failure. So you got that the slowing of the heart rate with the congestive heart failure. You got the hypertension as well. Age greater than 75 years, they're more likely to get that kind of symptoms. There's also diabetes mellitus. Diabetes is always going to be a risk factor for everything, and then stroke. So you'll notice that they're all scaled on a point system, and obviously if it's going to have more than 1 point, then they definitely need the therapy, right? So if stroke is worth 2 points, because they definitely need the therapy, because they're going to be probably the highest risk of having a stroke again. So If it's greater than 1 point, it usually means we can do oral anticoagulant therapy. So that can be like our DOACs, so like our apixaban, dabigatran, doxaban, and rivaroxaban, or it can be something like warfarin as well. And a thing to note about warfarin is you're usually going to see that in valvular atrial fibrillation, but you won't see the DOACs used in that one. If 0 points, but coronary artery disease or peripheral artery disease is present, then you're going to use antiplatelet therapy. So that's like your clopidogrels and aspirin. And if there are 0 points or no comorbidities, then the patient most likely will not need medication therapy. Okay, so now we'll get into the actual treatment itself with antiarrhythmic. So there's not really any difference between rhythm and rate control in terms of efficacy. However, rate control is usually the cornerstone if minimal symptoms, infrequent episodes, or normal sinus rhythm cannot be tamed. So let's start off with just pill in the pocket therapy. So this is just going to be used for paroxysmal, and if you remember what paroxysmal symptoms were, that was basically episodes that are less than 7 days, basically. Oh, that was a bad 7, but let's just, there we go. And infrequent symptoms, and it usually needs to be an immediate release formulation because you need it to work quickly. So this will include basically your non-dihydropyridine calcium channel blockers, so your verapamil and diltiazem. A beta blocker can be any beta blocker. These ones tend to be more popular as atenolol, bisoprolol, and metoprolol, especially atenolol and bisoprolol because they have a once daily dosing compared to something like metoprolol, which tends to be like a BID dosing. So it's better for compliance. And then you got your class 1Cs, which is your propafenone and flecanaide. One thing to note with the propafenone and flecanaide is that they're always going to be co-prescribed with a beta blocker, non-dihydropyridine calcium channel blocker. Man, that is a mouthful. So pretty much just no verapamil, diltiazem, or beta blocker, which is going to be like your backbone to this. So next we got is rate control, which is seen in patients with persistent or permanent afibrillation or aflutter. And again, it's going to be your verapamil or diltiazem or a beta blocker as your backbone, which is titrated to a resting heart rate of less than 100 BPMs. But make sure you don't want it to fall less than 50 because then you're going to be in bradycardic. And then next is digoxin. I remember this one used to be more popular, but now it's sort of it's only used as like a last resort if other therapies fail. And that's just because you need to do the loading dose, you need to do serum concentrations as well, and it's just the side effects usually just aren't worth it, right? And then rhythm control, which is basically returning the sinus rhythm back to normal. So this is usually preferred in younger and elderly symptomatic patients as well as recently diagnosed patients, usually less than 1 year of diagnosis, where achieving sinus rhythm is achievable due to improved stroke and mortality outcomes. For honestly, probably like the king of rhythm control is going to be amiodarone. Whenever you think of rhythm control, think amiodarone. This is the one that you're going to be used, right? So there is a couple scenarios where you're going to use certain medications. So that's heart failure plus your ejection fraction of less than or equal to 40%. You're only going to use amiodarone only. And remember, this one requires a loading dose as well. And then if it's heart failure plus an ejection fraction of greater than 40%, then it's amiodarone or sotalol. But make sure to be cautious in Torsades de points for sotalol because it can exacerbate it. And then just to note that these are class 3 antiarrhythmics as well. And then if it's just coronary artery disease, then you can just use amiodarone, sotalolone, or dronedarone. And dronedarone, the special thing about this one is it's preferred in thyroid patients, which I'll go over in the adverse effects. But basically, amiodarone, it has a very high iodine content, which can exacerbate like hyperthyroidism or hypothyroidism, for example, and it blocks that T4 to T3 conversion. So basically, in amiodarone thyroid is basically a no-no. If you can avoid it. And then pretty much all the therapies here are then amiodarone, sotalolone, dronedarone, and then your class 1Cs, which is flecanaide and propafenone. And then remember with your class 1Cs, you need to co-prescribe it with beta blocker or non-dihydropyridine calcium channel blocker. So you'll hardly ever see those ones by themselves. Okay, now see, these are just some kind of like odd treatments. So that's something like chemical cardioversion. And honestly, you'll probably only see this in an emergency setting, but they may ask a question about this on the exams. So you can use either flecanaide or profenadone, oral flecanaide or propofenin, which is your class 1Cs, or it's more likely going to be IV of either amiodarone, a butyladide, vernaculant, or procainamide. And I listed the classes there just so you kind of have an understanding which one's which. But honestly, these three you're only ever going to see in a chemical cardioversion. So that's why I kind of highlighted these ones, because like the only question they're probably going to ask is like, which drug would you use for a chemical cardioversion? And they'll probably be mean and exclude out amiodarone and then just throw those ones. So a way you can remember it is IV, not PO. So IV, ibutylalide and verapamil, and then PO, procainamide. And it's important because honestly, you're most likely going to use IV in emergency setting because it's an emergency setting, right? And then the next one is vagal maneuvers. So this is stimulating the vagus nerve, usually using physical maneuvers to increase the parasympathetic tone. And you usually want to use some sort of AV nodal blocking agent given IV. And this can contain your IV adenosine, IV beta blocker, or IV non-dihydropyridine calcium channel blocker, which is like your verapamil or diltiazem. And a way to remember that is you can just kind of remember like the ABCs of AV nodal blocking. Usually it's ABCD for digoxin, but I just kind of excluded that because I didn't see it in the CPS, which kind of goes over the therapies that are in that. So I just kind of exclude that there, but just kind of like for your reference, digoxin is also known to cause that AV nodal blocking as well. I'll put Digi for short for digoxin. And then there's catheter ablation as well, usually used for structural heart disease and usually requires complex follow-up. All right, let's go more deeper into the anticoagulant therapy. So this is going to be basically your AFib patients with a CHAD score of 0, but they have the coronary artery disease or peripheral artery disease, and they have 3 options for treatment depending on other factors. So they may do an elective PCI, percutaneous intervention. So that's kind of like something like oh, wow, why am I struggling for the word here? Like installing a stent into the heart. And this so this one is without high risk features for thrombotic event, so not really too big of a clotting event going to happen. So you usually use dual platelet therapy, so that's like your anticoagulant, so your DOAX or your warfarin plus clopidogrel for about 1 to 12 months post PCI, and then you're just going to use the anticoagulant therapy on its own. And then the other one is acute coronary syndrome with PCI, or you're going to use elective PCI with high risk. Let me just erase that for you so you guys can see this better, actually. There you go. So elective PCI with high risk factors for a thrombotic event. And so high risk features can be something like your diabetes or smokers, or maybe you have some genetic predisposition for like clotting, like thrombocytopenia. Would thrombocytopenia be like that? No, but anyway, so that would be like your dual therapy, which was mentioned above, or you can use triple therapy, which is an anticoagulant plus clopidogrel plus aspirin for 1 to 12 months post PCI, then anticoagulant therapy on its own. And then another one is acute coronary syndrome without a PCI, so you would just use dual therapy, which again, anticoagulant plus clopidogrel, and that's just because you're just trying to stop both ends of that clotting cascade, which is basically the antiplatelets and then your anticoagulants. All patients should receive a loading dose of aspirin at the time of PCI if they're aspirin naive, so they're not taking any aspirin. And you can discontinue it a day following PCI, or you may continue it. So for example, you might even continue it, in this case, with triple therapy. And then just some special doses considerations. just because as pharmacists, you have to know this is pretty much your bread and butter, right? So some big ones you'll probably need to know. This is probably the biggest one you probably need to know is the apixaban one. So normal dose is usually 5 milligrams BID, unless 2/3 of the factors are present, which is going to be age greater than 80, weight less than 60, or a serum creatinine of greater than 133. Then in that case, you're going to give a dose of 2.5 milligrams BID. And the reason for that is because these patients will be at a higher risk of bleeding. And you want to lower that risk, but you also want to lower the risk of developing a clot as well. There's also digoxin, which is 150 milligrams BID, unless their age is greater than 80. So then you would give 110 milligrams BID. So look at that. 80 milligrams is a common factor between apixaban and digoxin. And then pretty much edoxaban or rivaroxaban, you basically want to just lower to the next lowest dose possible if the patient has some sort of renal impairment. So creatine clearance less than 30. So that's like 30 milligrams and 10 milligrams respectively. I wish I had an easy way for you guys to kind of remember the apixaban dose, but honestly, that one's probably the one you're going to come up most often. And if you're in a hospital, you're going to see a lot more as well, especially if you're on the cardiac unit as well. But if you can remember the age greater than 80, it kind of at least helps you remember the digoxin and apixaban dose as well. Okay, so let's go over some adverse effects. So I'm not going to go over each and every single one adverse effects, but I feel like I'll go over the ones that you kind of need to know. But in general, all of them are going to prolong the QT interval due to the slowing of the heart rate, right? So it can put the patients at risk of Torsades points. And a majority of them are affected by CYP interactions. I did put some ones that are notable, so amiodarone. Just note that amiodarone is also a CYP inhibitor for certain CYP enzymes. And then dranderone, flecanaide, procainamide, and an interesting one about this one, all beta blockers are CYP2D substrates except atenolol. And also another fun fact about atenolol, it's only renally cleared, so it's not effect. So in case of some sort of hepatic dysfunction, you can use that one, and that's because it doesn't go under CYP metabolism, so it's a renally cleared, unchanged. So it's not affected by liver at all, so you can use that one if the patient has some sort of hepatic impairment. Okay, and then if you're giving basically any of these medications and combinations, like let's say if you give, I don't know if you ever see this, but like digoxin with amiodarone, for example, or amiodarone with a beta blocker, or verapamil with digoxin or something like that, you want to reduce the dose by 25 to 50%, especially if digoxin. And that's just to reduce the risk of bradycardia as well. And remember, digoxin has a very kind of like narrow therapeutic window as well, so you kind of need to reduce that dose as well. And amiodarone, oh my god, this is gonna have like the biggest adverse effects you've known to man. Probably the one that people mostly know it for is the blue Smurfs looking skin, which is a dermatological reaction. However, that one never comes up on exams, but it's like the most memorable one. The one that always comes up in exams is the thyroid. And like I mentioned earlier, it has a high iodine content, which can cause thyroid disruptions. That can be your hypo or hyperthyroidism. And it stops that blocking of the T4 to T3 conversion as well. So you make sure to monitor the patient's thyroid tests. You're going to do TSH tests basically every 3 to 6 months. And just kind of evaluate their thyroid function as well. So you're going to see basically in these patients, you'll usually see like a high TSH, high T4, but a low T3. So because of the disruption to thyroids, and thyroids controls all the metabolism of everything, you're going to get like various GI upsets, neurological, ophthalmic abnormalities as well. So pretty much it affects the whole body system. And in that way, it also has the large VD as well. And I also want to add that it also has a crazy half-life, like almost 2 months it'll take for it to clear out of your body, almost to get to half the dose in your body. And that's kind of why a loading dose is required, because you need to help quicken that onset of action. Now, now with amiodarone, you can increase the absorption by taking it with food, and as well, it would also help with the nausea as well. Dranderone, so remember this one is used in thyroid patients. It's preferred in thyroid patients because it won't cause that hyperthyroidism like amiodarone. Some noticeable ones like dyspepsia, diarrhea. You won't usually use this one in permanent afibrillation. Honestly, you probably won't use a lot of the rhythm control in permanent afibrillation because at that point you can't get a normal sinus rhythm back in permanent, and so you're just going to use rate control. Digoxin, so probably the biggest one is bradycardia, so that's like a heart rate of 45 beats per minute, less than that. And then probably a big one is the visual disturbances. So it's kind of like described as like patients seeing halos around lights. It also requires a loading dose as well. Verapamil, without fail, you'll always, whenever they ask about some kind of like side effect, just always associate this one with constipation. There's no like kind of mechanism action that explains it in a simple way, but constipation, just think verapamil, right? So if the patient's palliative and he's having arrhythmia as well, he's going to be on lots of opioid doses. And let's say he's just complaining about, the constipation, right? So you're probably most likely not going to use verapamil because that's going to increase that constipation as well. So just always associate with that one with constipation. And then of course you got the bradycardia and flushing. Diltiazem, pretty much bradycardia and hypertension, but I just wanted to note that there's one formulation, and I've remember seeing this on a question for one of the exams, can't remember where, but basically Tiazac XC. Um, the XC is basically this dose is given at bedtime, and that's to help with that morning hypertension. For pregnancy, it's going to be mostly like a risk versus benefits with that one as well. Remember, with some beta blockers, you're not going to use. Maybe aside from labetalol. Labetalol is safe in pregnancy as well. But remember, most antihypertensives are not usually safe in pregnancy, except for a few. And the way I usually remember that is pregnant women love meth labs. So that's basically methyl-dopa, and labetalol is a big one. And then I think you can also use, actually I'm not going to say because I'm not 100% confident at the moment, but I think you can use hydralazine, but yeah, no, I said it. Okay, ventricular tachyarrhythmias. So this is basically an abnormal heart rate of greater than 100 beats per minute, and that originates from the ventricles. So remember, supraventricular is more to do with the atriums. This one has to do more with the ventricles. Okay, and then patient presentation diagnosis will be similar, but will have a wide QRS complex. And these patients will often be asymptomatic. So there's two types. There's sustained, which is episodes that last approximately greater or equal to 30 seconds, and it's usually associated with some kind of structural heart disease, so like LV dysfunction. Non-sustained is episodes that last less than 30 seconds, and it's usually treated if the risk of cardiac arrest is high. Now, VTs we usually associate with QT prolongation. So I just kind of want to do a short spiel because it'll help with the understanding. Is the QT lengthens with decreased heart rate, and it shortens with increased heart rate. So the longer it is prolonged, it can develop into a polymorphic ventricular tachyarrhythmia known as Torsades de Pointes. And Torsades de Pointes is a huge red flag. Basically, if it lasts long enough, it can result in the death of the patient. So QT prolongation lasts long enough, leads to Torsades de Pointes, leads to death of the patient. And so what can cause QT prolongation? So basically anything that slows down that heart rate, right? So that's like conditions like bradycardia, a heart block, electrolyte abnormalities, hyperthyroidism, MI, HIV infection. I can't remember if I mentioned this. Sorry, so ventricular tachyarrhythmias, I think, I don't remember if I mentioned this, but they have a wide QRS complex where narrow tends to be more supraventricular. Okay, and these are some meds that prolong the QT interval. So probably the biggest ones you'll see is like the antibiotics like macrolides. So that's your azithromycin, clarithromycin, erythromycin, fluoroquinolone. So that's your levofloxacin, moxifloxacin, ciprofloxacin, certain antidepressants. So that's like the citalopram and citalopram, probably your biggest one, and certain FGAs and SGAs. Majority of them can cause the QT prolongation, but probably the biggest one is ziprasidone. And then obviously the antiarrhythmic drugs we just kind of went over, like amiodarone, dronedarone, digoxin, verapamil, and then you got domperidone as well, that can cause it as well, ondansetron and azoles as well. And then catheter ablation may be used with some sort of structural heart disease, such as LV dysfunction. Okay, so it's treatment. So immediate treatment for sustained VT, is going to be IV. IV amiodarone is great for electrical storms. If amiodarone fails, you can usually give like a mexiletine or quinidine, which is class 1A. Honestly, you're probably never going to see those ones. IV procainamide, is good for monomorphic VT, so that's like just your basic ventricular tachyarrhythmias. And then IV magnesium, okay, this is like one you really need to know is, oh my god, I didn't even write it properly. IV magnesium is great for Torsades de points, and I was trying to find the reason of like why it's great for Torsades de points, but basically it's kind of like thought to block calcium channels during repolarization, and that suppresses that early after depolarization, that which leads to Torsades, and so that's why I think it's used. And then you got your IV beta blockers, which is your metoprolol, azamol, propranolol, and for an electrical storm, it's shown that propranolol seems to be better, like superior-wise in efficacy compared to metoprolol. And then your chronic treatment, basically going to be your beta blockers. So beta blockers are basically going to be your bread and butter for all your arrhythmias, right? So they're preferred especially in stress or exercise-induced VTs. And usually, like I mentioned earlier, atenolol and bisoprolol are usually preferred because they have the long half-life, which allows for that once daily dosing. You can also use metoprolol as well. And then you can also use amiodarone and cetalol. There was some kind of like evidence now saying they're not as effective, but still are treatment options that you can use. And then I just want you to notice that there is no non-dihydropyridine calcium channel blockers. They're not indicated for ventricular tachyarrhythmias. You're only going to see these in your SVTs, okay? So that's kind of like one less thing for you to remember. But beta blockers you're going to see in both. Same with amiodarone as well. Although amiodarone is not as much as a key player in this one compared to supraventricular tachyarrhythmias. And then adverse effects, honestly, I think pretty much the only one you need to know is quinidine is a PGP inhibitor. And the reason I mention that is because you will be using DOACs as well. And pretty much all the DOACs are affected by PGP and CYP except dabigatran. Dabigatran is the only one of them, as far as I remember, is the only one that's not affected by CYP, but it is affected by the PGP interaction as well. And then mexiletine, honestly, you're probably not going to run into this one, but pretty much the only one you need to know is CNS side effects for that one. But you're hardly ever going to see it. Alright guys, so I know that was a little bit long. We just cut it under at least half an hour. But I hope that helped. Let me know if there's anything more you want to see. And I really hope that the this microphone made a better difference and makes my voice more clear. Alright, good luck on your exams, guys.